Welcome. I am glad you're here. I just wish that we were all together. Best I could do is put a picture up there so you could put a name with a face. And my name is Kathy O'Donovan. I'm registered in EEG and CLTM. My specialty is pediatrics, outpatient, ICU, LTM, EMU, and neonate. Love that stuff. I've also been a clinical instructor teacher for an accredited program in EEG at a local college, and I volunteer time to the GOHE mission, the Global Organization of Health Education, and I've got a handful of brilliant students in Africa that I get to work with as they pursue their registration, where I get to teach them and give them lectures and respond to any questions that they have, and that's something I really enjoy. Shout out to Go He. And I want to thank Rebecca Clark Bash for giving me this opportunity to speak to you. And we will go ahead and get started here. Non-epileptic seizures, what's a tech to do? That's certainly a big subject. A lot of us have seen these patients, and some of us may not have, and this will be very informative for you, but some of us have seen a lot of it, and there's a wide range of reactions that techs have to it. And that's one of the things that I want to go over in this. There's a lot in here about techniques to help us get what we're trying to accomplish that will help the patient get an accurate diagnosis and be led to treatment that will actually help them. So let's go ahead and get started. Okay, here are a couple of, or a few just facts to be aware of. So first of all, when patients come into a clinic or see a doctor and they say that they have uncontrolled seizures, 20 to 30% of the time, a good 35% of the time, after a bunch of review and some testing, it turns out that these symptoms that appear to be seizures or are talked about as seizures and they're being treated, a good 25% of the time, they've been misdiagnosed with epilepsy. And that's not really what they have, because a doctor has seen them and listened to the family or the patient describe what's happening. And if they don't have good access to EEGs and things like that, or if they come in and it seems like it's really urgent, a regular neurologist or other kinds of doctors that may see these patients in the emergency room or whatever can often just put them on AEDs, and the AEDs don't fix what's going on. And us techs are absolutely in my opinion, the most crucial factor that is going to get these patients going in the right direction and get the doctors, create the ability for them to be able to accurately see what's going on and then move forward with a treatment that's going to be effective. So that's what we're going to talk about here. When we're talking about non-epileptic seizures, these are seizures that by nature are not caused by epilepsy. And our mind usually goes to the ones that we call psychogenic non-epileptic seizures, or PNES, and that's what we think of as non-epileptic. But there are actually a lot of things that will cause seizures that are not epileptic. It's not because they have a chronic problem with the electricity in their brain going haywire and causing a seizure because they've got a tumor, or they just have irritated tissue or whatever. There are other reasons that are not going to respond to AEDs that it's because of another problem. And let's look at some of those. For one thing, drug and alcohol abuse and withdrawal, especially alcohol withdrawal, seizures are very common. But what's the cause for it? You're not going to throw an AED at them, because if they stop drinking and they're not having withdrawal, then they're not going to have seizures because of alcohol withdrawal. Same thing for drugs and all that. So that's not epileptic. It's a non-epileptic seizure they're having no matter what it looks like. Electrolyte imbalance, same thing. There are electrolyte imbalances that will cause seizures, and they are genuine looking seizures. You wouldn't be able to tell them from an epileptic seizure, but it's not something that will be fixed by anti-epileptic drugs. It's going to take correcting the electrolyte imbalance, and then the seizures go away. And you know, the definition of epilepsy technically is 2 seizures in your lifetime. You can have them 20 years apart, doesn't matter. When you have the second one, you have epilepsy. Well, with electrolyte imbalance and some of these others, they can have more than one seizure. You can get, have alcohol withdrawal problems multiple times, but that doesn't mean really that you have epilepsy the way we think of epilepsy. Same thing with electrolyte imbalances and some of these others. Infections. Infections cause seizures. It can go into sepsis, and sepsis causes seizures, and they're genuine seizures. And if it's status, they very well may treat it with AEDs, but if the infection can be cured, then the seizures disappear because it's not generated by the brain. Severe hypoglycemia. We're talking about babies that are born to a diabetic can have this problem, or type 1 diabetics can have, lots of episodes of hypoglycemia where their blood sugar drops so low that they have seizures. And frequently they're GTCs, generalized seizures, and they can certainly have more than one, because anytime their blood sugar gets to a super low level, seizures are frequently part of what happens. But what's going to fix that? An AED? No, absolutely not. Bring their blood sugar up and it's going to fix itself, because it has nothing to do with electrical activity that is provoked by something wrong with the brain. It's something wrong is with the blood sugar itself in these cases. What else we got here? High fever, febrile seizures that are not uncommon in the young ones, the babies. They have a high fever, have a febrile seizure, and a lot of doctors will even recommend, if a seizure is associated with a fever, they won't even order an EEG. The only way they would do that is if it becomes chronic, or it lasts too long. If they go into status with it, and a lot of times they'll give the parents a rescue med to take care of it and just tell them how to treat it. But an AED is not going to fix seizures that are caused by a really high fever. So is it epilepsy, or is it just a non-epileptic seizure, right? So there's a couple others here, and there's really more than just this, and we'll talk a little bit about that, but trauma. Trauma can cause non-epileptic seizures. And same thing with sexual abuse. Any kind of abuse or trauma can cause stressors that change the brain and can just somehow, the way it works, it just gets to where some patients with certain sensitivities will the way they react to it is to have something that can look to the ordinary person like a seizure. And when I say ordinary person, I'm talking about family and just general people in the public, teachers at school, doctors even that are not neurologists, or certainly, epileptologists would be able to tell the difference. But um, anyway, a lot of these kind of situations, and there are patients, definitely more of them are in the adult population and especially more likely to be men, but they will have non-epileptic seizures or fits for monetary gain because they are trying to get cleared to be on disability and continue disability income. Things like that. There are ways to get money that'll, having a seizure of some kind or having something that looks like a seizure can aid you in that process, they believe. Now, I want to add a caveat to the previous slide that this is not to say that there aren't people who do this for monetary gain, because there are. And, it happens. It happens. But we can't react to everyone like they are having these episodes for selfish reasons. So just keep that in mind. And now what are we going to do? The EMU is the gold standard for distinguishing between seizures and non-epileptic events. It is the gold standard. Got to catch it on video simultaneously with the EEG, and then the doctors can figure it out and guide the patient to a proper diagnosis and treatment. I want to say that I have personally been involved with a lot of these patients. We see them a lot in teenage girls and, any teenager, but teenage girls it's a very prominent population group to have non-epileptic seizures. So provoking the seizures is a responsibility of the tech that we should take very seriously. And that is the thing that will move this patient to the next stage of getting treatment that is going to help. And if we do it the right way, then we can make it much easier for the doctor to hold their hand and walk them to the right professionals that can effectively treat these events that they're having. So, and I'm going to talk about later how to be suggestive, but being suggestive as soon as you walk in the room, and asking them about their history and treating them as if you want them to have an event. And so that kind of suggestiveness really can be very psychologically powerful. You're going in and saying, oh, while you're hooking them up, and you're saying, okay, so tell me what all happens. Well, why do you think that happens? Have you found anyone that has been able to figure that out? What have other doctors said? Oh, wow, gosh. And they're telling you that, they just got their driver's license and then it got taken away, or, all these interruptions to their life, and their friends are thinking they're weird, and, their job got affected, and, they're scared they're going to have one at their job, and they're upset because the medication they've been given isn't working. And so you're going to be listening to all of that and talking to them and getting them in the mindset of, I'm a person that has these events. And that's just part of the, combination of things that will help trigger one, because that's what you want. And I have a thing about using the word seizure. I know that it's controversial or controversial. Sorry about that. But there are a lot of us that don't like the word seizure used with non-epileptic because we fear that using the word seizure is going to give them the wrong idea and make it harder to convince them that these are not seizures. I, on the other hand, and I use the word seizure with these patients and really these patients only. Any new onset patient that I get, even if I've seen video and I have heard the description and I know absolutely without a doubt that those are seizures, um, I always call them events. I'm not the doctor. I don't diagnose. So I call them events. Now, if they've been told they have a seizure disorder, then I might say, okay, when was your last seizure? But otherwise, I don't. But with these patients, I definitely use the word seizure, and there's a reason behind it. And of course, you can't do this if the place where you work doesn't want you to. But if they don't mind, then using the word seizure can be effective because it makes them feel like you heard them. They are saying the word seizure because they believe that these are seizures. Now, these are not medical people. Why should we be holding them responsible for thinking of them as seizures? It sure feels and looks like a seizure to them based on what they've seen on TV, right? So if you use the word seizure, that lays the groundwork for them feeling heard and believed, and it validates for them that they are having experiences that need to be addressed. And it's not up to us to help them understand that these are not epileptic. That is not in our bailiwick. So us using the word seizure and taking everything seriously is not us being complicit in them believing the wrong thing. That's the doctor's job. Let them carry that burden. Our job is to bring these people in with compassion and give them what they need, which is validation, because they haven't gotten it anywhere else. And that's part of the problem. Sometimes it can be hard to distinguish between epileptic and non-epileptic. Sometimes it's very easy just clinically watching them to tell. Sometimes not as much, but there are a bunch of different little things that are clues. Now, let's just go ahead and establish what we know about epileptic seizures. And since they tend to come in with presenting with generalized type seizures, big things, then this is very helpful. With genuine epileptic seizures, the eyes are open and the jerking is very rhythmic and powerful and very precise. You could set your clock by it. And they have a rigidness to whatever they're using to have their event. It's a stiffening that can't be interfered with. You wouldn't be able to bend their elbow if their arm is stiff because the brain is commanding the muscles to be tight, and no outside force is going to be able to make that happen. So in addition, if they have seen or know something about seizures and they're doing eye deviation or their mouth pulling to the side, then they won't know that in a typical seizure, if eyes are deviating, they can deviate so far that it would not be humanly possible to make that happen without your brain ordering it. Your mouth will be pulled very uncomfortably to the side. You'll see all the muscles in their neck and face stretching to that side where they're deviating, and their eyes will be going all the way into the side of their eye, and their head will be forced into the pillow, and you can just see the strain as their muscles are forcing that. So keep an eye out for that, because that's those kind of things are for sure going to be legitimate, most likely, I should say. This is a real seizure, and I just wanted you to see something that demonstrates what I was just saying about what a real seizure actually looks like. And just so you know, All these videos here have been posted to YouTube because I have a number of videos, but they've been posted to YouTube by them or their, their families, whatever. And there's no HIPAA thing going on here, just so you know. Now, he starts out, he's kind of breathing, but I want you to notice how he's looking off to the left. And in the earlier parts that I cut out, he was, just looking around and looking off to the left, and he was kind of breathing heavy. So I wondered if he had had a seizure before, and then his wife grabbed the camera, and the camera's kind of shaky. So don't worry about that. And here we go. And you'll see him do a real fast blinking, and like his eyes twitching, and they're going right, and they're going really far right. And now his head is just gradually going to the right, and you'll see the strain in his neck as his head is being pushed against the pillow there. And that's not something that anybody would naturally do or be able to do even. It's just the muscles are being forced. Baby. His eyes are open. Now what's going on with his throat, you can't make that happen. Same thing with these noises and everything that's happening orally for him. That's not something you can make happen by trying.
Baby, come back.
She was probably trying to make sure he was safe. And you see his whole body is jerking. And his hands are in that, one of those positions that is typical for focal seizures like this.
Baby, come
complex
back.
Partial. And now see that foam? You can't make that kind of foam come out of your mouth. That's
Baby, come back.
You will never see a non-epileptic seizure look like that. They wouldn't be able to imitate that, okay? Now, if it's non-epileptic, how do you tell? How do you tell the difference? Besides all of that, how do you tell? So these are some features of non-epileptic seizures, and I'm talking about other than the ones that are created by hypoglycemia or, other medical issues, infections and fevers. I'm talking about non-epileptic seizures that get classified under that psychogenic or pseudo seizure heading. So they almost always are going to present as GTCs because people that have them, that's the only way that that's all they know about seizures, is that they are big and outrageous and all of that. So they, unless they've gone and done research on the internet on how they should look, and I don't know, everyone I've ever seen, they are GTCs. They also typically, their eyes are closed, not always, but their eyes are closed. And if they're open, then they are, usually there's people around the bed and they are looking at the reactions of people because they want to get a sense of whether or not the people are reacting as if they believe it if what's happening is concerning the people around the bed. They want to judge that, so they'll look around. And also, since they present as GTC, they're doing stiffening and jerking or some combination of all of that, but they can't sustain it very long. With a epileptic seizure, that's going to go on until your brain stops forcing it to go on, and you are going to be so sore afterwards. But with non-epileptic seizures, you can't sustain that by trying to do it. So they'll frequently, like, it'll settle down and they'll take a little break, and then when they gather enough energy, they'll get started again, and they'll go back and forth between, and sometimes if they're doing it on one side, they'll switch sides. So they'll switch sides, and the movements are generally disorganized. They cannot create the kind of rhythmicity that the brain can create. And some of them are better at it than others, and I've got an example of that. But as a rule, there's going to be disorganization about it. And for example, they will have their arm outstretched, but the hand will be loose, or it won't be a rhythmic movement. And if they're if they know enough about seizures, and they did look it up, if they're trying to pull their mouth or deviate their eyes, it's not very convincing because they can't do it like the brain can do it. Okay, yeah, I've covered everything there. This is a video of a woman, and she posted it to YouTube saying non-epileptic seizures are real. And this is a very good example. Notice her husband's in the background cooking some bacon, and see how disorganized everything is, all of her body movements, and there's really no stiffness to anything. And her head will start shaking around, and then it'll stop, and then her legs are doing the work, and she eventually wears out and takes a break. So now she's got a pause where she's catching her breath. It's very hard to sustain this. And I suspect, and here she's getting ready to get going again, I suspect that she has been to a lot of emergency rooms, and they've been dismissive, and they told her it's not real, it's in your head, you need to go see a psychiatrist. And so putting this up on YouTube is her attempt to find if there's anybody that will take it seriously. Now watch what she says here at the end.
Could someone help me to the couch?
So the lady you just saw, that is classic non-epileptic seizure. That's what it looks like. And the way that you can, when you are in the EMU, because that's the gold standard for doing these, here are some things that you can do that will help evaluate it. And it's really good if you can catch all of this on video. So if you're in the patient's room or coming over a microphone, well, some of this you can't do except in the room, but the doctor documenting what you are doing is going to help the doctor, because their job is hard too, because they're going to a lot of times meet some resistance. So if you see anything about their body that's trying to be stiff, try to bend the joint. And you don't have to say, hey doc, I just bent the joint, so this isn't real. Yeah, no. Just demonstrate what you can do that would prove whether it is or not, because of abnormal activity in their brain. You can get a cup of water and stick your fingers in there and flick water on their face, because people will react to that, especially if they aren't noticing you. They don't see you doing it. You know, come around from the side, do it discreetly, and it'll surprise them, and that'll be captured on camera. And you always want to make sure that there's nobody in there that's in the way of the camera. It's very important. You can also tickle their feet, you know, tickle them, and they'll react to that. They can't help it. And give them some instructions. I've found that a lot of them, especially if they've been trying to sustain it for a while, you ask them something like, oh gosh, is it about over? You know, and just keep asking them questions that will sort of lead them into responding to you. I hope you're okay. Are you okay? Any kind of response they give you would demonstrate that it is non-epileptic, because you cannot have anything generalized and be able to respond. That's the nature of generalized seizures. You're not going to be responsive. So you can get them to respond anyway. Even saying, okay, just nod your head if you're okay. You know, that kind of thing. Just look for any kind of reactions they have to what's going on. You could ask the nurse something about, when should we get the Ativan shot? And if you see them react to that, you know, even if they're not saying anything, you know, all of those kinds of things, you know, if you're allowed to say something like that, but just anything that you can capture on video that will demonstrate that they are aware, able to respond, all of that. That's all going to be helpful in establishing the diagnosis that is needed for the next step. When the EEG is running with a non-epileptic seizure, there's nothing to see here except lots of muscle. You're not going to see anything going on other than that. This is from a TV show, and it's a really good example of someone that is good at knowing how to look legit. And you can still see some telltale signs, but this guy has looked stuff up, and of course he's on a TV show, so he's probably got a consultant. But
I
here
don't
we
know
go.
what you're so upset about, Buttercup.
I don't know what you're so upset.
I told him that we didn't work
Buttercup.
together, but that we do.
I told him that we didn't work together, but that we do.
Hair, chair. Sure what?
Hair, chair. Sure what?
So you can see the disorganization.
That's it.
So you can see the disorganization, and he's got stiffening, and he's doing some things that would really make you question it. But if we were able to watch him for longer, it would start to become clear. And of course, you've always got the things like splashing water in their face and all of that. Now this one is a young man or teenager in the hospital, and these are, you know, that note that's on the video about fake seizure, that I can't get rid of that, but this is clearly someone who wants people to believe that he has seizures, and he reacts every time somebody comes in the room, and you'll see what I'm talking about.
Okay. Yeah, they got on a meeting for today.
So he's doing this for every new person. And I think a family member or something must be recording.
So are you from Atlanta? Selena?
The doctor's going to look at all that stuff on those patients and will determine these are not epileptic. So he's got the hard job of going in there and gently and respectfully guiding them to the right kind of treatment, because medications are not going to fix, or AEDs anyway, are not going to fix what's going on with them. And so he's going to have to be really judging from the way they're reacting. And he doesn't have well, I guess a lot of times they have a way to anticipate it, because parents will come in and say, or not just parents, but patients, I've been to 4 emergency rooms and every single one of them tells me that these are in my head, but I know that these are not in my head. These are real seizures. So when it's like that, and that's what the majority of them are going to do, he has got a really hard job. So he comes in and brings them the good news that, okay, thank goodness these are not epilepsy. So you don't have to worry about epilepsy. You can be taken off of those medications you've been taking, because I know you were complaining about this and that side effect. So you can actually go off those meds, because that's why these events are not stopping. And you can be driving again. I'll sign the note that you can drive. You'll be able to get back to your regular life. And he'll have a nice, good, respectful, and compassionate conversation with them about everything. Now, they can react multiple different ways, and a lot of times, though, this is how they react. They get irritated with the doctor, and they already sensed it, because the tech that hooked them up was rolling her eyes and giving them attitude. And every time the tech came in, they just acted irritated, because from the tech's frame of reference, they were thinking, and they don't know this, but sometimes what we do is we know that these are not real seizures. So these people are wasting our time. This is ridiculous. And that kind of thing leaks out whether we want it to or not. But they do. They'll get mad. Okay, so this is what I think is going on. They are being told that they have psychogenic seizures, and they don't hear the word genic. Not that that would make any difference. All they hear is psycho. That's it. And they shut down, or they're told, you've got quote, fake pseudo seizures. And no bueno. That is just, they shut down, they stop hearing anything, and they are prepared to push back against everything, because they've been working so hard to get someone to believe them. Now, when they're told they have psychogenic seizures, all they heard was psycho, so they think they're telling me I'm crazy. And these kind of images come up, because they're thinking, I'm not crazy. They don't know what they're talking about. These people don't know anything. And they say they're real doctors and nurses and stuff. They don't know what they're talking about. That's what happens. And with the pseudo seizures, that's what they think. That's what they hear. They're told pseudo seizures, they hear faker, and they remember all the people along the way, the other places they've been, that have told them these are not real, they're in your head, you need to go see a psychiatrist. And so they're feeling dismissed by yet another set of negative minded healthcare professionals. One more health professional. I'm just going to put another notch on my belt, that here's yet another one telling me that I'm crazy and I need a psychiatrist. And they can be. I'm not saying everybody's like this. I'm just saying that this is what can happen is they feel like nobody's listening to them. They're not being taken seriously. They're being dismissed, ridiculed, shamed, and they're hurt. They're very offended and angry, or can be, and they feel like people are just looking down on them as if they are somehow inferior because they have fake seizures or psycho seizures, right? And they feel very alone because, as a rule, they don't know that anybody else does this, and they feel pretty desperate because there's something going on that they want and need addressed. Okay? A patient walks in feeling like this lady here because of all the places she's already been. Now, what can we as techs do? What kind of responsibilities can we take on that will change everything for her? First of all, we can set up the doctor to be successful. And the way we do that is how we treat the patient and the sense that they pick up from us, whether or not we are compassionate, whether or not we believe them. And we can believe that these things happen and this is what they look like and all that. We may suspect that these really are not epileptic seizures, but they have something going on, right? So we need to be in their corner. And that is the kind of thing that sets the doctor up to be successful, because if they experience acceptance and not being dismissed and that you're concerned about what's happening to them, they're going to be much more open, not a little more open, but much more open to what they're going to hear from the epileptologist. Something is wrong and it needs to be addressed. They need treatment. They may not need AEDs. They may not need to see an epileptologist, but they deserve to be in a healthcare setting evaluated by medical professionals. They deserve that. They need that because that's how to get them to the treatment. They need to feel heard. And not judged. When they feel us rolling our eyes at them, and they can feel it, I'm telling you, if you feel that way, you cannot keep it from leaking out. You don't have to say a word about it. You can say all kinds of nice things, but they're going to feel it when it's not genuine. Not mocked. When we go in the lab with our colleagues and we're laughing as we show each other the non-epileptic patient that just had this fake seizure, and that's how we're doing it, that it leaks out whether you want it to or not. They need acceptance and to be taken seriously by everybody that walks in that room. And again, don't be afraid to call them seizures unless you have objections that your manager or whoever it is that you report to, the doctor, is objecting to using that word. And I'd make a case for it just because I think it's so effective at helping get an event. But they need to be guided. And the tech, I think us techs have the most effectiveness at being able to guide them towards successful treatment by how we treat them in the period of time that we're running this EMU study before they get this diagnosis from the doctor. Okay, I'm sharing here some of the responses to that video, and there were a lot of responses to it, and all those view replies, those represent her responses to these people, where she is patiently trying to help them understand that these are real seizures that she's having. So I'm doing this to show you the general, the way people react to it. And this is what these patients are getting daily from just the community, and then they go to the hospital and they get the same thing. So this first one here says, I mean, really, hell, I've looked like that at a Pink Floyd concert. Laughing. Um, Another one, I have PNES, psychogenic non-epileptic seizures. Doctors think I'm faking, but why would I want to fake such a painful and life-altering thing? She's got a point, you know? And, you know, they may not be doing it to get attention. There's something under the surface that plays a role. So another one says, hey, to her old man back there who continues cooking, good for you. And I know of a really good attorney's office if you want to get out of that mess. I mean, think about that. Here's one, ha ha ha, and her old man back there continuing to cook. He knows what's up. Laughing. There are places for people like this woman called asylums. I mean, that's what you're reading. Another one just says faking it. And then this bottom one in the middle, fake. If it were real, she would have been falling out of her chair. And she sure was aware of stranding afterwards. I don't know what that means. Another one, ha 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 ha. And this husband is so done with her. This is fake. By the way, honey, I know real seizures when I see them. I'm an ICCU nurse and have seen all kinds of seizures, and this ain't it. So there she's got yet another medical professional mocking her because of this. And this last one, I don't know what's worse, her faking this seizure, real seizure, or pseudo seizure, I don't care. She's faking it to get attention, and she's doing a bad job at that. She manages to stay in her chair and have abilities to have eye contact periodically. Anyways, I don't know if this woman is worse for trying to fake her seizure or her man ignoring her and continuing to cook his breakfast. So that's what this patient runs into, and that's painful. Now, this is something I personally ran into on a Facebook group that I belong to called ZPAC, and it's run by a physician in California who is trying to change healthcare. Lots of nurses, every kind of medical professional ever is on there, including little old me. So there was a thread going, and I pop in on those anytime I see them, about pseudo seizures, okay, fake seizures. And this lady responds to some comments that I had made about, like I've talked to you, you know, that these are very real to the people that are having them, and we need to treat them with compassion. And, you know, a lot of times they have abuse in their background and they need treatment, but getting in front of our eyes is how they get the treatment if we do the right thing in guiding them there. So Robin posts on here, and she says, from someone who suffered pseudo seizures as an 11-year-old child, I thank you from the bottom of my heart. I had years of physical, mental, and sexual abuse. I guess one day in my mind I just couldn't handle it anymore. I had many seizures. Some of them I remember, some of them I don't. I ended up in a mental hospital for a month. I was considered crazy by my family. Unfortunately, the abuse didn't stop until I moved out at 16, but the seizures stopped. And then she says, I responded to her on that, and she said, I survived and I am stronger for it. And then she tells the story of her being, it sounds like a nurse's aide, and being in the ICU, and there was a patient there that had pseudo seizures. And she says several of the nursing staff and doctors acted negatively toward that patient and about that patient. And she said that when she told those doctors and nurses her story, it helped some of them change their stance. So the attitude of the professionals changed toward the patient because of this CNA that shared her background. And it says, come to find out the patient was part of a sex trafficking ring. And she says, thank you again for standing up for patients like us. Now, talk about that anchoring my belief about this in my soul. And I hope that this story that spontaneously, and this was just a few months ago, this spontaneously came up in a thread. And just me going on there and with words giving some legitimacy to what these patients are experiencing. And, you know, what will benefit them. And then my statement that a lot of times there is abuse in the background and the stress becomes so much that they just end up having this kind of a stress reaction to it where they're having this, quote, pseudo seizure. And I hate that term. So just think about that for a minute and what we can do, like that CNA did, that will get that patient toward the treatment that they really need. Now, I have a story for you about, I call it my Camp Spike and Wave story. And this was also very solidifying for me. And I was working in an EMU, and a nurse that I worked with went to an annual camp for kids with seizures called Camp Spike and Wave. And she came back and was telling me this story about this young teenager who had, you know, and she was talking about it creating a lot of drama, but this young teenager who was having all of these events that looked like seizures, but they suspected really weren't. And so they were just trying to kind of placate her, but she wasn't getting like in front of a doctor. So she kept she kept doing it, and it was becoming really disruptive. And, you know, they'd have to get a wheelchair for her and wheel her out someplace to settle down. And finally, they decided to get the doctor on staff. And, you know, being a camp for kids with seizure, there's seizure doctors there. And they got a doctor involved. And next time she had one, they took her to the doctor. And of course, the doctor talked to her privately. And it turns out that this child was living in a home full of abuse. And because she was doing something that got her in front of a doctor's eyes, he was able to find that out and intervene and get her out of that situation. You know, contact the authorities, however that's done, and get her rescued. So I just want all of us to understand that there is often more to the story, and just saying, well, they're trying to get attention. Well, maybe they're trying to get the attention of medical professionals because there's something going on. And that's not every single time, but I think the vast majority of the time there is something going on in their lives that is causing these behaviors, and they need to be under our eyes. And us techs are usually the first prolonged contact they have with the medical world. They may start out going to a doctor or an emergency room, but those are not prolonged contact. That's not a one-on-one, like personal, that lasts more than 15 minutes thing. We're the ones that they see time after time, showing them compassion and hearing them and believing what they're telling us and not questioning whether or not it's real or whether or not it's epileptic. We know that what's happening to them is real. We just need to find out and be part of the guidance process that the doctor is going to have to engage in, and set it up so that their ears will be open and they'll be relieved to hear that, because it's not like people walk in a hospital very often with these kind of events that I'm having these fake seizures because I've got some abuse going on at home. That, we need to be sensitive, and really our hearts need to be softer toward them, and not see them as somebody who's just faking it to get attention, and then they're bothering us by taking up our time when that bed should really belong to a real epilepsy patient. Because the gold standard for determining, and this is the gold standard, just known as the gold standard for distinguishing between epilepsy and seizures that are not caused by epilepsy, is a stay in an EMU at least 24 hours and extended in order to capture an event. And us techs are the ones that can make that happen by suggestiveness and all of that. We can make that happen. Sometimes I've made it happen a lot, especially with hyperventilation, because you just get them to do it for a lot longer, and you give them special tasks while you're doing it, and you keep asking them if they're wearing out, and you ask them to raise their leg, and okay, you got to hold it in the air, and you have them holding their air in the leg, and then okay, now raise your left arm straight up. It's got to stay up. Don't let it go down. Well, eventually that will, the only way for them to get out of that, they start to believe, is to have a seizure. And so you'll be able to capture one. So when we use those kinds of approaches, we can be successful, and with compassion, we can hand them off to where they're really going to be able to get effective treatment for what's going on in their lives. So in this significant role that we play, compassion, don't let the patient feel like you're annoyed with anything, and that means that you can't feel annoyed. You have to change your mindset. If you have that mindset, you need to try to change on that, because it will leak out. You can't stop it from leaking out. They're gonna see it. And when you set the doctor up for success, run a fabulous EEG. Take the time to provoke those events, and all the while protect their dignity and self-respect. We don't want to make them ever feel like we think they are fakers, okay? And do all the event testing while it's going on to help validate or invalidate what's going on. And when we do all of, we can change someone's life. And I'm not kidding. We can change someone's life, because the abuse, they can be extracted from that abuse. And the ones that are doing it for not abuse, treat them the same, and they'll still be passed along to the professionals that can give them the help they need. Now, I want to say that this is actually a very passionate subject for me, and what I want you to know is that I am thrilled to be able to share these thoughts as a tech that I have about this subject with each of you. I hope that we all come to understand this, and I'm not saying that you don't. I want to, if you're on the same page as me, I want to validate that for you and just share my experiences so that you can continue to believe that the naysayers are not correct, because all of us are surrounded by naysayers that make fun of these kinds of patients. So I have really enjoyed getting to do this, and I really appreciate your attention, and let's keep talking about this subject, because it really is all about making a difference in these patients' lives.